Hi, I'm Dr. Jacqueline Nicholas, and I'm the director of the MS Center at OhioHealth. And we're so happy to have you guys here with us on Saturday morning to talk about hot topics in multiple sclerosis. I'm joined by my colleagues, Dr. Dan Smith and Dr. Andrew Smith, who are MS specialists here at OhioHealth. And I'm also excited to have Lauren Esposito, who's a doctor of physical therapy, and John Piper, who's a PT assistant, who are here with us today. So just a couple of housekeeping items as we get started. You are going to hear separate presentations, and following each presentation, there will be a question and answer session. So in the Q&A, you can feel free, if you're logged into YouTube, to go ahead and write your questions in the chat box. And then if you are not logged in or you have more personal questions that you'd like to ask, you can put them to an email, neurowellness@ohiohealth.com. Just as a reminder, we are not going to be answering questions today directly about your personal health concerns or disease course, but more generalized questions that'll help the whole group. So thanks so much for joining us. We're going to go ahead and hop into a video of our entire OhioHealth MS team. So let's get started. Hi, I'm Dr. Jacqueline Nicholas, and I'm the director of the MS Center here at OhioHealth, and we're so happy to have you with us today.
Hi everyone, I'm Dr. Douglas Wu, and I'm the OhioHealth multiple sclerosis provider here in Athens, Ohio.
Hi, I'm Dr. Jacque Nolan. I'm the current MS fellow here at the MS Clinic at OhioHealth.
Hi, I'm Dr. Andy. I'm a provider at the MS Clinic at Riverside and Pickerington.
Hi, I'm Dr. Dan Smith. I'm one of the MS neurologists at Pickerington and Riverside.
Hi, my name's Jeanette Ripley, and I'm one of the nurse practitioners in the OhioHealth MS Clinic.
Hi, I'm Laura Poplar, and I'm a nurse practitioner.
Hi, I'm Colleen O'Connell, and I am one of the nurse practitioners at the OhioHealth MS Center.
Hi, my name's Diane Massey-Angelo. I'm one of the nurse practitioners here in the OhioHealth MS Clinic, and I am based primarily here at Riverside.
Hi everyone, I'm Amber Love. I am Dr. Andrew Smith and Dr. Jacque Nolan's medical assistant.
Hi, my name is Terry Anderson. I work here at the MS Clinic with Dr. Jacqueline Nicholas.
Hi, I'm Sarah and I'm a medical assistant.
Hi, I'm Courtney. I'm a licensed practical nurse.
Hi, I'm Patty Stevens and I'm a physician office specialist.
And we work at the MS Clinic at OhioHealth.
Hi, I'm Sarah.
Hi, I'm Ashley.
And we're the nurses at the OhioHealth MS Clinic.
Hi, I'm Casey.
Hi, I'm Katania.
I'm Andrea, and we're part of the nursing team at the OhioHealth MS Clinic.
Hi, I'm Morgan. I'm part of the scheduling team and the MS Infusion Center.
Hi, I'm Terry West, practice manager for the MS Clinic at Riverside Hospital.
Hi, my name is Tracy Paxton. I'm the social worker here at the MS Clinic.
Hi, I'm Connie. This is Keosha, and we're part of the OhioHealth MS team front desk.
Hi, we're part of OhioHealth Neuro Rehab, working out of the MS Clinic. My name's Alyssa, and I'm one of the physical therapists.
My name is Kate, and I'm one of the occupational therapists.
So I'm glad you all had a chance to see our team, since we do have to be distanced right now due to COVID. That way we could see everybody who's part of this wonderful team. So before we get started into the exciting science updates regarding MS, let's get started with a fitness break. And so I'd like to turn it over to Lauren Esposito, Doctor of Physical Therapy, and John Piper, PTA.
Hi everyone, we are so excited that you are joining us today. We wanted to start this event off right with a short activity burst. We're going to get our muscles pumping and we're really going to prime ourselves to learn with this amazing lineup of speakers. My name is Lauren and I'm going to lead you in the intermediate level workout, which will be primarily in standing. And feel free to grab a hold of your chair for balance if you need it.
Hi, my name's John. I'll be leading the exercises chair base for beginners. Again, if you need any modifications, make those adjustments as you need them, but we'll be giving recommendations.
Now, I'm not checking my text messages, but I am going to pull up what's called a Tabata timer because we're going to do an interval-based workout today. So you may hear some countdowns. So we're going to start demonstrating our first exercise, and I will tell you when it's your turn to go. So we're going to be marching. Your turn. Hit it with us. We're going to be doing about 45 seconds of work and then 15 seconds of rest. So one really important thing is that we are pulling up those knees as high as we can. We are swinging those arms and we're really bracing with our core. If you can pick up the pace a little bit and get a little breathless during this exercise, it's really a cardio portion. So after the interval, we'll tell you we're going to keep exercising so you can get a sneak peek of the next exercise to come. We've got about 10 more seconds, so just hang in there with us. Pick it up if you've got a little bit more of a burst in you. Let's go, guys. Come on. All right, you guys take a rest. I'm going to demonstrate the next exercise. So it's going to be a squat with an overhead reach. And John's demonstrating, like we said, that version if you're staying in the chair. Okay, so you're going to join me now. So squat and reach. Really sink into those heels and then reach overhead. And even if you're in the chair, press down. You'll see that John is leaning forward. He's activating through those legs. He's bracing with his core. It's not about moving fast. It's about slow, controlled movement. So turn that core on. Shift your weight when you're reaching, guys. There we go. Now, I hope you're not just watching us exercise and you're getting the benefits right along with us. Got about 5 seconds left. Great, take a pause. Everyone's gonna come to their seat. So the next exercise, you're gonna lean back with your feet elevated. Our chest is open, and you're gonna tap your heels. Go ahead. Now, if you need to hold on for a little bit of balance, that's great. If you start to feel like you're slumping, you can put those feet down and do a march. The most important thing is staying upright. This is really working those core muscles, bracing throughout your trunk.
For the modification, stay seated nice and tall. If you can't lift one leg, that's okay. You can keep your toes on the floor and you can do heel raises, but keep your posture nice and tall.
There you go, guys. Keep it up. Open up that chest. Don't get into couch potato posture. All right, and rest.
All right, now I'm going to be leading you into a nice posture stretch where we're going to stretch our chest. So you're going to be seated towards the edge of the chair. You're going to have 1 foot forward, 1 foot back. And what I'm going to have you do is you're going to grab the chair, the backrest, and you're going to sit up nice and tall, lean forward, and squeeze your shoulder blades together.
Now, John, should I be focusing on my breath at all here?
Yes.
Or just breathing normal?
You should. You can take a nice couple deep breaths while you're holding this stretch, and you can further the stretch when you breathe in through your nose and out through your mouth. Okay, now take a second and just kind of relax, move the shoulders around, and let's switch your feet.
Great, we're about halfway through.
Now we're going to sit up nice and tall and go back into the stretch. Lean forward, squeeze those shoulder blades together. Don't hold your breath with this one. Try to keep your shoulders down. Don't let them hike up towards your ears. And this is a really good stretch to do if you spend a lot of time in the chair, either at home or at work, because it helps with your posture to sit up taller.
All right, so the next exercise we're going to do, guys, is a low jack. All right, let's do it. So again, we're trying to get our heart rate pumping. So move those legs and arms as fast as you can. Now you'll notice John has kept his arms down. If you're having any shoulder pain, there's no need to go overhead. Keep it shoulder level and get the benefits of raising your heart rate and getting a little breathless here. Come on. Now, if you can do a full jumping jack, I'm never going to hold you back. So go for it. But I'm going to stick right here with my low jack. Come on, guys. About 5 more seconds. Keep it up, keep it up, keep it up. And pause. I'm going to grab my chair for this next one. So we're going to be doing a lunge. If you want to hold on for balance, you can. But start with that arm extended, and you're going to lunge forward. Go ahead and join me. So as we're lunging, we're shifting our weight, but we're keeping our knee stacked on top of our ankle. You should be able to see your toes. Now you'll see John is staying seated, but as he's rotating, he's pressing his heel down and he's engaging his trunk. He's activating those lower extremity muscles and getting the benefits. We are about 15 seconds left in this workout. And we got 2 more exercises for you. You guys are doing fantastic. Keep it up. All right. Take a rest. Again, demonstrating the next one so you know what's coming. You're reaching overhead and you're going to pull down. The important part of this is really squeezing those muscles in your back. So we opened up that chest and now we're activating those muscles. Let's do it. Pull down and hold. Reach overhead. Pull down and hold. Now again, you'll see that John is keeping those arms a little bit lower for anybody that has shoulder pain. Exercise should never be painful. So we're working in our available range and strengthening all of those muscles to help stabilize our shoulders. And exhaling. Got about 15 seconds left with this one, and then we're going to end with a stretch. Pull down and hold. Nice job, guys.
All right, guys, last exercise, we're going to get back to the seated position. We're going to be working on rotation. So you're going to be seated tall at the edge of the chair. You're going to take one hand, reach across to the other leg. Other hand, reach back, grab the chair or the sofa, wherever you're sitting, and you're going to sit up nice and tall. Take a nice deep breath. And then when you let it out, rotate and breathe out. Good, and then take another breath in and let it out, and then rotate a little bit more. If you encounter pain or strong resistance, don't push through it.
I'm really feeling my heart rate kind of come down here, so that's what you should be feeling as well.
Good. All right, now gradually come back to center. Keep that posture tall. Okay, now we're going to switch sides, so reach across, grab across your leg. Other hand reaches back, grabs the chair, and take a deep breath in. And when you let it out, rotate. Use your arms to kind of rotate you a little bit more, but keep the posture tall as you breathe out. Good. And take another deep breath in. And then rotate a little bit more. Again, don't push into pain. Good. And let's bring them back to center.
All right. Thank you guys so much for joining us for our Get Moving session. As you can see, we did this burst without any equipment. All you really need to get a workout in is time, space, and most importantly, a little dose of motivation. So thank you for joining me, John. We hope you learned a few new moves to add to your workout routine. And for those of you who don't know, OhioHealth has quite a few options for virtual fitness classes right now, and you may even see a familiar face leading a lot of those. Please let us know if you're interested in learning more. We'd love to have you joining our community. And now it's time for our main event. I'm going to send it back to Dr. Nicholas, and I hope you guys enjoy what we have in store for you.
All right, well, thanks so much, Lauren and John. That was fabulous. Now that we've got our muscles moving and our minds ready to learn, I'm excited to turn it over to Dr. Andrew Smith. He is an MS specialist at the OhioHealth MS Center. He has had excellent training. He did his neurology residency at Case Western Reserve University in Cleveland, and then he went on to do his multiple sclerosis fellowship at the esteemed Cleveland Clinic Mellon Center. So we'll go ahead and turn it over to Dr. Andrew Smith.
Hi, my name is Dr. Andrew Smith, and as Jackie introduced, I'm one of the MS doctors at OhioHealth. I generally go by Dr. Andy to make it easier, given that there is another Dr. Smith in our group. So these are my disclosures. In no way did any of these companies have any hand in preparing these slides. They're all coming from me today. So what I intend to talk about today, what are vaccines, how vaccines work, are vaccines safe? Spoiler alert, they are. The AAN guidelines about vaccines and MS, and then some more specific MS and disease-modifying therapy points and vaccines. So a vaccine typically is either active or passive. An active vaccine actively stimulates your immune system to develop immunity towards something. Typically it's a weakened or killed or sliced up form of an organism or toxin. Sometimes we can give antibodies or lymphocytes as passive immunity. That's generally we do to try to prevent a primary infection. Vaccines can be given orally, like the old polio vaccine, intranasally, like the live flu vaccine, or as everyone comes to expect, the good old injection. So there are two basic types of vaccines, live and non-live, and this differentiation is very important for people with multiple sclerosis because we generally typically do not recommend live vaccines while people are on disease-modifying therapies. So there's two types of live vaccines. There is the attenuated vaccine, which is typically a weakened form or a form of a virus that is grown in a culture that it can't produce an infection or typically does not. And then there's the heterotropic vaccine, which is typically an animal antigen. This is most classically the cowpox vaccine that was used to treat smallpox. Below are some more examples of live vaccines. Non-live vaccines are the vaccines that typically most people can get. Whether or not how effective it is depends a little bit on what disease-modifying therapy you're on, so it's important to discuss this with your neurologist. Conjugated vaccines take the surface of a bacteria or some other antigen and has your immune system react to that. The classic example of that would be the pneumonia vaccine. A subunit vaccine is when they take the infectious element and dice it up so it's no longer infectious. An example of this would be the hepatitis B vaccine. A toxoid vaccine is they use an inactivated toxin in order to help your immune system realize it and neutralize it so it can fight off if you ever got the actual toxin in your body. Classic examples of this is the diphtheria and tetanus. And then inactivated vaccines are inert antigens that essentially are the viral particles, but they're either killed via heat, radiation, or some type of chemicals. And listed below are some common examples of non-live vaccines. So if you get nothing else from my talk, vaccines are very safe. They're one of the safest interventions that we have in all of medicines. And for the most part, they are all highly effective. In fact, they're victims of their own success. People really do not see a lot of polio anymore, or measles, mumps, and that's because of how effective these vaccines are and these vaccination programs have been. In fact, other than these outbreaks that have happened recently, you would have to be in your 70s to have lived before these vaccines started. Additionally, there's always questions about this. There have been 13 large, methodologically sound, controlled epidemiological studies, that's not a phrase I can say 5 times fast, that has demonstrated that there is no association between autism spectrum disorders and the MMR vaccine. So going into the AAN guidelines about vaccines and multiple sclerosis, the AAN, or the American Academy of Neurology, is a society that most neurologists belong to in the United States. It, some ways, is a governing body that comes up with recommendations. Every so often they get together, review all the data on a topic, and they come up with guidelines for the rest of neurology to kind of follow. So they did this last for vaccines and MS in 2019, and one of the things they clearly said is that there is no evidence to suggest that vaccinations increase the risk of developing MS in your lifetime. In fact, there are several studies that suggest the HPV, tetanus, pertussis, and smallpox vaccines were actually associated with a lower risk of developing multiple sclerosis. Another thing that's important to realize is, regardless of whether or not you have MS, your odds of getting an infection if you're unvaccinated is the same as a person without MS. So if you haven't gotten vaccines, we highly encourage you to do so. There's sparse data that exists that suggests whether or not vaccines increase the risk of MS relapse. The data that we do have does suggest that there is no association between vaccines and having a relapse. We strongly recommend getting a flu vaccine every year if you're an MS patient. Depending on the disease-modifying therapy, we might tell you when to get it, but we do highly recommend getting the flu vaccine, unless, of course, you've had a severe reaction to it in the past, which is phenomenally rare, or are allergic. We also recommend that we screen for appropriate infections before starting any disease-modifying therapy. We recommend currently that patients on disease-modifying therapy do not get any active or live vaccines, and we also state that people who are in an active relapse should also not get any vaccines. This is highlighting some of the risk with specific vaccines. There was originally a concern that the human papillomavirus vaccine, or Gardasil, increased the risk of MS. This was a large study in the Journal of the American Medical Association that demonstrated that there was no increased risk of developing multiple sclerosis after the vaccine. This is another, a little bit more complex slide looking at measles, mumps, and rubella. If you look at the rightmost portion of the slide, you'll see that this p-value statistic is what we generally look for in statistics to say if something's real or not. And we see none of these numbers are less than 0.05, which means that MS did not increase the rate of, risk did not increase if you did get the MMR vaccine. The tetanus vaccine is associated with a 1/3 reduction in MS risk versus no vaccination, taking a meta-analysis looking at all the studies that looked at tetanus vaccine risk and MS. We used to think that there was potentially an increased risk of MS relapse after yellow fever, but from the International MS Conference this past year, they actually did a larger study looking at the yellow fever vaccine. The original study had about 14 patients in it, suggested that there may be an increased risk. This study that was presented this year looked at over 100 patients, and it demonstrated that there was no increased risk of annualized relapse rate, or the number of relapses that people had in a year, in the people who got the yellow fever vaccine versus those who did not. So this slide, I apologize, is a little bit complicated. I was hoping that I could have a laser pointer that could show this off. The highlight of the slide is get your yearly flu shot, and if anything else you get from this, get your flu shot. Talk to your provider about the timing of this. So the top, it represents essentially days from getting influenza to being hospitalized. So you see the top one, there's kind of this peak right on day 0, and that peak represents when people got the flu and the likelihood that they were going to be hospitalized, and it's significantly higher than the background. The bottom graph shows essentially people getting the flu vaccine and the risk of being hospitalized. And there is no real difference in that pattern. It kind of looks the same if you look at the front and the back, your risk of being hospitalized. So overall, not getting the flu vaccine increases the odds of getting the flu and being hospitalized. So therefore, once again, we recommend getting your flu shot unless you have a contraindication and talking to your provider about it. This slide is a little bit complex, but it kind of shows how various disease-modifying therapies respond to the flu vaccine. And basically what this shows is that certain disease-modifying therapies blunt the response to vaccines a little bit more so than others. So the top blue line represents people with MS in general. The bottom tan line represents Gilenya. So although the effect is blunted when you get a vaccine on Gilenya, it still does have some response. So we generally, even though the effect may be blunted, we do recommend that you follow through and get a flu vaccine. So we also look at how disease-modifying therapies affect hepatitis B. Roughly the injectables, which would be Copaxone and interferons, roughly don't affect a person's ability to respond to the hepatitis B vaccine, nor does natalizumab. Some of the orals actually do have a slightly decreased response rate, and it would be important to talk to your provider about timing of vaccines if you had to get the hepatitis vaccine, depending on what disease-modifying therapy you're on. Now we're looking at the vaccine response to Tecfidera and interferons versus various types of vaccines. Interferons classically don't appear to affect the immune response much to vaccines, so that's the reason why we generally always compare other disease-modifying therapies to interferons. For the most part, Tecfidera patients respond as well as people getting interferons when it comes to getting vaccinated. The exceptions would be the tetanus and the pneumococcal vaccines. The response is a little less, but this is not statistically significant. Another common oral agent is teriflunomide or Aubagio, and once again, most people have a response to the influenza vaccine while on Aubagio. The notable oral agent that has a decreased response of responding to the vaccine is Fingolimod or Gilenya or S1P medication. So that would also be ozanimod or Zeposia or siponimod and Mayzent. And it reduces the likelihood of seroprotection from influenza vaccine. However, even though it reduces the likelihood of seroprotection, generally about half of people still get an effect from it. So therefore, we'd still recommend that you get the vaccine every year. So this is another complex slide that I wish I had a pointer that I could show you, but essentially kind of looking in the last column, essentially none of the patients on Tysabri versus those in a control group who weren't getting Tysabri, they generally all produced antibodies to a level that was protective. And I'm getting towards my last slide right now. So prior to starting a disease-modifying therapy, we generally recommend that non-live vaccines be given at least 2 weeks prior to going on a non-cell depleter disease-modifying therapy, and then 4 to 6 weeks prior to a cell depleter. Cell depleters are most classically the CD20 agents, the Kymseta, the Ocrevus, the rituximab, Lemtrada would be another one, Cladribine would also be another one. Additionally, we recommend for live vaccines, they should be given 4 to 6 weeks prior to essentially starting a disease-modifying therapy. Over on the other side, I have the washout periods that are recommended for pretty much all several disease-modifying therapies, about how long we think the medication should wash out before we recommend essentially getting a vaccine. Once again, this is a little bit controversial and every neurologist does kind of a different approach. So it's always a risk versus benefits discussion with your neurologist. So if you have to get any vaccines, particularly live vaccines, essentially it's important to talk to your neurologist. So in closing, I want to leave you with a couple points. First, vaccines are safe. They are highly effective. We encourage people in your family to get vaccines as appropriate. We encourage you to get the flu vaccine every year unless there's some medical reason why you can't get it. We recommend talking to us to better figure out essentially what our next, to talk to your neurologist about timing of vaccines if you do have to get one. And I have a little bit of time, so I'll briefly ask, answer some questions. So, should we expect a COVID vaccine? I believe that there will be a COVID vaccine sometime soon. We don't know which one will come to market first. However, this will be a discussion that you'll need to have with your neurologist depending on what the vaccine looks like and how exactly the one that makes it to market works. So I believe at the point where I'll turn it back over to Jackie.
So thanks so much, Dr. Andy. So we have a couple of questions coming in. Just as a reminder, if you have questions, please feel free to enter them in the chat box if you're on the YouTube Live. And if you can't access the chat or you'd rather, you could also send your questions to neurowellness@ohiohealth.com. So next question we have coming in for you, Dr. Andy. Should MS patients avoid close contact with someone who hasn't had their flu shot?
So the answer in general is yes. However, that's not necessarily something that can always be done. So although, for the most part, most of these disease-modifying therapies only mildly suppress your immune system, you are at an increased risk of catching influenza from strangers. So if it's an issue where you're going to a party and someone has the flu, I typically advise people to avoid the person who actually has the flu that will be there. But realistically, if it's your child, you can't necessarily avoid your child for a prolonged period of time. So we would encourage you in those situations to make sure you practice good hygiene, washing your hands frequently, keeping a trying to avoid touching your face after taking care of your child, and try to do all that stuff. Overwhelmingly, almost on all of our disease-modifying therapies we use, the likelihood that if you caught the flu, the likelihood that you would end up hospitalized is still not that greatly increased if you were off the medication. So looking at even one agent like ocrelizumab, your odds of getting an upper respiratory infection were roughly once every 2 years getting the medication compared to those who did not, which was once every 2.5 years in its original clinical trial. So once again, it is a slight increased risk of infection, and yes, you're at a slight increased risk of having a bad infection. But overall, I would say that you wouldn't have to avoid people, but if you could, I would. But if you can, if it's your kid, obviously you can't, just try to keep yourself safe and practice good hygiene.
So another quick follow-up to that. So what if, I have MS and I've gotten my flu shot, but I have a family member who can't get their flu shot for some reason? Is it okay for me to be around them, or am I protected because I got my vaccine?
So for the most part, if you have the flu vaccine, you're more protected than you would be without it. As we said, some of the medications do blunt the effect of the vaccine. But I would say that if one of your family members had the flu and couldn't get it, I would not necessarily avoid them. But once again, it's kind of always a risk and benefit.
Thanks. So we have a question that's a little bit unrelated to your talk, but would like to just ask, can you give just a brief couple-minute overview of thoughts around MS, pregnancy, and breastfeeding?
So this is actually a question that generally comes up very commonly because MS classically affects women more commonly than men, and it generally affects women in their 20s to 50s, generally when a lot of people are having children. For the most part, what we can say is that pregnancy appears to be at worst a neutral thing, and this goes back to a study in the late 1990s, essentially demonstrating that women who got pregnant generally would have had the same amount of relapses in the year that they got pregnant as if they didn't get pregnant. So worst case scenario is that you will be no worse off than you would have been if you did get pregnant. Pregnancy in itself appears to be a highly protective time in people's lives with MS. Commonly, particularly in the third trimester, estrogen and progesterone levels get so high that people actually, there's some data suggests that people actually get some healing. It's very common for me to hear that a woman will tell me that the best she felt in her life is in the 3rd trimester of pregnancy. So the risk of relapse goes down profoundly in each trimester of pregnancy and then goes up higher to kind of counterbalance that reduced risk in the 1st trimester after pregnancy. So we do recommend that, if you're a woman of childbearing potential and you want to have kids, at this point we do recommend, unless for extreme circumstances, if you have very bad or aggressive disease, we're generally okay and we'll work with you so you can plan a safe pregnancy. In regards to breastfeeding, there is some data to suggest that breastfeeding may be protective and blunt some of this increased relapse in the postpartum period, but you have to exclusively breastfeed. There's still a lot of research going on in these areas, and there is some research to suggest that potentially pregnancies could help reduce the risk of progression of the disease as well. But once again, this is still some rather preliminary data. And I would suggest that it's always important to tell your provider if you're ever thinking about getting pregnant, so we can come up with a way that you can do it safely.
So can you explain to us what you mean by exclusive breastfeeding?
So exclusive breastfeeding is the process of where the only food the baby gets comes from breast milk. So there's no supplementation with formula, and typically this is to know if you're doing it enough. Typically, women will not have their periods returned if they're exclusively breastfeeding due to the hormonal changes that come with exclusive breastfeeding.
You know what's interesting? I really, this is a topic that we're very passionate about, and it's important to know that a long time ago, women with MS were actually discouraged from becoming pregnant and having children because doctors mistakenly thought that it was pregnancy that worsened MS. But, as you've said, Dr. Andy, it's wonderful to hear that pregnancy is actually protective. And there actually was a small study that showed that women who became pregnant and had children after their diagnosis of MS, that they actually did better in the long run than women with MS who were pregnant prior to the onset of their MS or never pregnant. So this is one of those things that's great, and thanks for highlighting it, Dr. Andy, that if you are a woman with MS and you want to have children, working with your MS team to find the right time and making sure that you're approved to proceed based on what disease-modifying therapy you're taking to fight your MS, or whether or not you need to come off of that, that you can really successfully do that. So we've had a lot of serious questions. I want to just ask you, Dr. Andy, can you tell us a little bit about yourself and maybe something fun about you that we don't know?
So something fun about me is I'm actually an avid traveler and I love to scuba dive. So before COVID, I would generally try to go scuba diving once a year. And if you ever have enough time with me, I can show you a lot of photos from the sea floor. Another fun fact for me is, given that I'm wearing red and you can't see my gray slacks, is I'm an avid Buckeye fan. And I know a bunch of people will be watching the game after this with me, so go Bucks.
That's wonderful. All right, well, thanks so much, Dr. Andy. We really appreciated your excellent talk and for clearing up a really complicated topic, vaccines and MS. Thank you so much. So next, I'm excited to turn it over to another one of our MS specialists here at OhioHealth, Dr. Dan Smith. He comes to us through training at the University of Cincinnati, where he completed his neurology residency, and then he went on to the University of Colorado and did an MS and neuroinfectious disease fellowship at the Colorado Rocky Mountain MS Center. So really excited to hear this topic of promise and hope that so many patients with MS are interested in. So thanks so much, Dr. Smith.
Thank you, Dr. Nicholas, for the introduction, and thank you everybody for your time this morning and logging in for our session. So today I'm going to be focusing on updates on remyelination therapies as well as neuroprotective therapies. And to kind of get started, I thought first what I would do is let's talk about exactly what is myelin. So this is a mixture of proteins and lipids that forms a covering, almost like a sheath, around the nerve fibers that leave nerve cells, which are called axons. You can see on the bottom left a cartoon of a nerve cell with sort of its communication arm coming off the side of it. That's the axon. And around that axon, you'll see this protective myelin coating. So what this does is it helps to improve the speed of the electrical signal that's moving from one nerve to another. You could almost sort of think of it in a similar way that we would describe some insulation around an electrical wire. Without myelin, the speed of the electrical signal is much, much slower. If you take a look at this cartoon on the bottom right-hand side of the slide, the very first picture is a cartoon of an axon that does not have myelin. It's unmyelinated. And what happens when it comes to moving the electrical signal down this, there are certain places along the axon where the current is generated and where it passes. And these are called the nodes of Ranvier. And in this unmyelinated nerve fiber, what happens is as the electrical signal moves, a lot of the heat and the energy is lost. It's a really inefficient way for the signal to move from the left to the right. But if you look on the bottom, you'll see an example of a myelinated nerve fiber. Here, what's happening is the signal is moving from one node to the next, and you can see those big kind of fluffy green things are the myelin encasing that nerve fiber, helping to protect it and helping to move much faster. So myelin is very important, and it also requires a lot of maintenance and upkeep. So there's a cell in our brain which is called an oligodendrocyte, and what this cell does is it helps to protect and upkeep the myelin, as well as, in cases, remyelinate. This is a cartoon showing what one of these oligodendrocytes looks like, and it's right very close to an axon that you can see there. This is a picture of what these look like at the level of the electron microscope. Now, these things are very impressive, so they can actually, in a given day, produce up to 3 times their own weight in myelin. So they're very capable cells. However, to do this, it takes a lot of energy. So to do all this work, it takes a lot out of our system. When there's so much energy that's being used that there's a lot of waste products that are created. And these waste products actually are bad for us. And so these are what we call reactive oxygen species. It's really, really important that we also have a way to get rid of these with antioxidants. The other thing is that there's a lot of iron. That's one of our elements that's involved in making this process happen. And the iron can also build up. So what you can see is that this process is really complicated and it works really well, but there's also a lot of places where this process can be very vulnerable. I'm going to take a minute and tell you a little bit about the precursor to an oligodendrocyte, which is called an OPC, or an oligodendrocyte precursor cell. This is sort of our brain's source of remyelination capability. So you can see here in this cartoon sort of the progression of this OPC slowly becoming a full-blown oligodendrocyte, and that's the adult form or the fully formed version of this cell, which is able to help produce myelin. This is what it looks like at a much closer blown up level. The number of OPCs that we have does go down as we age, but we do maintain them throughout our lives. And what they do is they tend to move to areas of the brain based on chemical signaling, certain areas that may be sending out a signal that remyelination is needed. Now, when the myelin is made, it is not quite the same caliber of the myelin that we're born with. The myelin is a little bit thinner and it's a little bit shorter, and it is still better than nothing, but it's not quite as good as the original myelin that we're born with. Some important things just to keep in mind, and this is important particularly for the scientists who are helping to develop some of these treatments. It seems that certain areas of the brain may be more receptive to having new myelin placed than others. And the other thing that's important to keep in mind is that if there is in general a lot of inflammation in someone's brain, even with remyelination, it may be harder for that to stick around. So if new myelin is put down, but there's a lot of inflammation going on, it may be harder for that to really stick and to stay. So we've talked a little bit about this process of demyelination. What I want to do is show you what it looks like on pictures. So here's an MRI of the brain, and what you can see with those white arrows are areas of prior MS damage. When an MS attack first happens, there's a lot of inflammation, and as time goes on, sometimes the inflammation becomes more smoldering and it almost leaves behind a scar. That's kind of what we're looking at here in this picture. Sometimes the myelin is affected, but the axon, or the cable underneath, is not as affected. Other times, unfortunately, the axon itself is actually damaged pretty badly, almost to the extent that the axon may degenerate and go away. And sometimes this leaves behind what is known as a black hole on MRI imaging. You can see on this brain picture the areas that are dark, kind of near the middle. Those are areas where the axons themselves have actually been lost from prior damage. And sometimes these are also thought to be areas that are maybe more effective and more, more symptomatic for patients. Let's look at a very, very close blown up picture of an axon. If you look at the picture that says AX1, what that is an axon that is myelinated, and you can see that thick black coating all around the sides of it. If you look at the one that says AX4, what we're looking at is another axon that has lost its myelin but has been remyelinated. And you can see that it still does have a thin rim of black covering around it, but it's not quite as thick as the first one. But if you look at the bottom right, the one that says AX2, that's an example of what an axon looks like that has not remyelinated. And what you notice is that it's almost kind of swollen, it's almost kind of irregular looking, and it's not as compact and organized as the other ones look. And so when demyelination happens to one of these axons, we see that there's changes that are happening at the level of the actual at the level of the cable, where the channels, the sodium channels that move this electrical signal, actually get reorganized in a new way. What this ends up amounting to is that it takes a lot more energy to do the same job, and it's a lot less efficient. And unfortunately, the byproducts tend to accumulate around these areas. And so the idea here is that if too much myelin is lost, our system has to work a lot harder to do the same amount of work. This is very taxing on the cells that are still there to help pick up the slack. The byproducts tend to accumulate, and sometimes when that happens, cells that are normally supportive start to change and be bad. So this is a cartoon that shows this thing in the middle, which is a neuron cell, and next to it there's a red one called an astrocyte and a blue one called a microglial cell. So these are normally good cells that we want to have around in our brain, but sometimes when the environment changes and there's buildup of these waste products, these types of cells can actually, unfortunately, start to have a negative role. And so what happens is sort of this cascade, one event leading to another, where there can be actual degeneration and loss of some of the nerve cells and their axons. And we feel that this is probably the mechanism behind progression, or in other words, feeling worse neurologically despite not having new separate areas of injury. So to change gears, one important question is, how do we measure demyelination and neurodegeneration? We've shown pictures of it on MRI, and we've looked at these other blown up pictures of the cells themselves, but how do we measure it in the clinic? So one thing that we look at is atrophy. So this is a picture of someone's brain scan changing through time to slowly losing some of its size and its volume. Other ways that are fancy and new and coming about are ways to look specifically at some of the white matter, which is really, really full of these axons. And this is a picture that looks specifically at the white matter tracks, like within the brain, that you can see outlined. We also have ways to look up at the optic nerve, which is a nerve that connects the eyeball to the brain, that we see that this nerve can become thin as well as some of its myelin protective covering is lost through time. Neurofilaments are an up-and-coming thing as well, which are going to be looked at within both spinal fluid and blood to help us understand maybe when someone is having new attacks or relapses. And one important question will be, how well can we follow neurofilaments when it comes to the question of this sort of slow degeneration? And then in the clinic, we look at certain things like someone's walking speed, someone's cognitive processing speed, as well as even the 9-hole peg test to test upper extremity function. These are all ways to sort of help us gauge how someone is doing and perhaps if there is some effect of neurodegeneration. So here is a slide that basically shows on the bottom left an important concept. And what this concept is that it seems that in some cases early on in MS, what we sometimes experience are attacks. If you follow that green line, someone may be feeling worse clinically due to certain exacerbations or relapses that are happening. But then as time goes on, they may continue to not feel good, but it's a different reason for that. And specifically, if you look on the bottom, it shows you that the new MRI activity is actually going down. There's not so much that there's new lesions happening, but what does seem to be happening is that the brain volume, which is that red line, seems to slowly be getting worse, and maybe one reason kind of driving this. And so the reason to go through all this is to highlight the importance of why understanding this helps us understand how we should probably be thinking in the future to keep attacking MS. Right now, what we're focusing on so much are immunomodulatory medicines, things that are really helpful at preventing new inflammation, and they're awesome, and it's great to have them. And what we want next are ways to help repair myelin and also to help protect the nerve cell itself. And you could almost think in the future of our way going about this as sort of a pyramid, where our base are those anti-inflammation medicines, but then adding to them other types of medicines for other purposes. So let me go through some examples of a few types of remyelinating agents. This is certainly not an all-inclusive list, but I just wanted to highlight a few specific kind of interesting examples to give you. There is a protein which is called LINGO, and it lives on the surface of these oligodendrocytes, and you can see a cartoon of it on the right. So LINGO basically makes the oligodendrocytes stay quiet. And the idea behind a therapy called an anti-LINGO that you can see in the red is that can we give a drug that basically allows LINGO to stop what it's doing? It's almost an effect of taking your foot off the brake. Can you get the oligodendrocytes to start making myelin? It's a really neat concept to have. The idea, though, would be certainly if someone's going to respond to a medicine like that, probably what they want to have is they want to be able to have axons that are there that need the myelin. So maybe it won't work as well on someone whose axons have been lost, but maybe just the right sort of person would respond to this therapy. That was the hope, and there's been a number of trials that are listed here that have sort of looked at this question. Unfortunately, even this week, we got some unfortunate news that one of the bigger trials, which is called Affinity there on the bottom, didn't really prove to show that this type of therapy helps significantly with patients who are taking it. The very details about that have not quite been released yet, but we expect more information to come. We don't necessarily look at this as bad news, that this medicine has no hope or purpose in the future. It'll be interesting to see maybe through time if there are certain groups of people who might respond to this if given in certain ways. So time will tell about this type of therapy. I want to tell you a minute about an interesting thing which is called a HERV. It stands for a human endogenous retrovirus. So believe it or not, our DNA is not just our own DNA. We actually have DNA in our genomes from old viruses that affected our ancestors in the past. If you can believe it, almost 8% of our genetic code is actually made up of these viruses. So they're almost thought of to be as hitchhikers. They have genetic material in our own cells. And the question is, what does that mean for us day to day? So the presence of this material has been implicated in certain types of neurological problems, including MS. And very quickly, this is a picture of a cell, and the thing I want to highlight is if you look in the middle of it, basically the idea behind this stuff, this HERV, is that maybe it's inserting its DNA into ours in ways that either leads to the production of problems that shouldn't be there, and maybe even certain proteins. If you look at that green on the bottom left, that's viral protein that's being made from this genetic material and secreted out of the cell. And what happens is that this, again, if you look at the green protein, this green protein may be having an effect on our immune system. So that big thing in the middle of the picture is a microglial cell. And what's happening is when this green protein from the HERV is going to the microglial cell, there's inflammation that's being made. The microglial cell is being inhibited from doing its normal job. It's not doing a very good job of cleaning up debris. And also, if you look at number 3, this green protein seems to affect the OPCs that we mentioned earlier and prevent them from making the myelin. So this has led to an idea of, can we target this protein to help to get rid of it and help improve outcomes. A lot of the data on this sort of therapy is still very preliminary. We don't have a huge amount of information on it, but there have been some clinical trials that are early on that have suggested possibly some benefits when we look at things like brain volume loss and other measures of myelin. Okay, I'm going to go kind of quickly through this. So there's another thing I want to mention quickly called a mesenchymal stem cell. So mesenchymal stem cells are basically things that our body has in them, and they are able to make different types of tissue, sort of rebuild tissues within our body. Not only are they able to do that, but perhaps they have an effect on our immune system as well. And so a lot of trials have looked at the idea of using our own stem cells, our own mesenchymal stem cells, to help our immune system. So this is something that is, again, up and coming. A lot of the information that we're seeing is kind of in phase 1 and in phase 2 trials. But the idea here would be, you know, can we find ways to use sort of the machinery that our own body has to help rebuild and regrow? So we've talked about ways that new fancy drugs are being designed and developed to help people, but then one question always comes up is, what about things that are already been around for a long time? Can we refurbish or reuse known medicines? So clemastine is an example of this. This is an old antihistamine from the 1960s, which has been shown in some early studies to maybe help improve the speed of electrical signal in the optic nerve. Simvastatin is a type of cholesterol medication that we use commonly and has shown some benefit in helping to reduce brain atrophy rates. And there's a large study that's going on now, a phase 3 study that's looking at this question in a bigger group of people. Abudilast is another medication that's very familiar to the eastern part of the world and not as much here in the United States. It's been used in Japan and Korea to help treat asthma for a long time. And it is felt to be protective potentially at in MS. A phase 2 trial that was pretty well known was published 2 years ago in the New England Journal of Medicine that showed that this therapy did have some benefit in reducing the rates of brain atrophy, though perhaps didn't really help people feel better clinically over that period of time. So more is going to be investigated about this drug surely as we go on. So my last slide to conclude is that what I kind of just did was give you a very brief overview of some of the up-and-coming therapies that are out there. But one question, of course, is, well, what can we do right now as we await these things to be prime time and usable? And I think it's incredibly important to emphasize that there are things that folks can be doing right now. We need to really promote a healthy brain environment. We need to try to do things to reduce inflammation in the brain as much as possible. And so of utmost importance, it's controlling comorbidities like high blood pressure and diabetes, weight loss, and stopping smoking. I really can't say enough about that. And exercise as well. Regular aerobic exercise is certainly beneficial when it comes to brain inflammation. And so even though the certain medications may not be something that we're out there prescribing right now, focus on this for now because it is absolutely of utmost importance. And so stay tuned for more developments as they come, I think, in this field. And with that, I'll go ahead and stop and be happy to take some questions here.
Thanks so much, Dr. Smith. That was fascinating. I feel like I could listen to you talk about all those exciting areas of research all day long, but we've got a Buckeye game to get to, so we won't do that. So I just want to ask you a few questions that are coming in from the chat. You summarized nicely some healthy moves and lifestyle in MS. Are there things that people with MS can be doing to protect their myelin?
Yeah, so this is a great question. And yeah, to reiterate, the healthy lifestyle things are absolutely crucial here. The other important thing is to be on an effective disease-modifying therapy if your MS is at a point where it's still able to have new inflammation and new damage. And so we, in addition to healthy lifestyle, having a good and close relationship with your MS provider, making sure that the drug that you're taking is doing the best job that we can to help keep myelin healthy. The existing myelin that is there is how I would say we should focus for right now.
A lot of the studies that you mentioned are very exciting, and there are certainly some ongoing studies and up-and-coming studies in remyelination and repair. How, if somebody is interested and they have MS, how can they be a candidate for those studies? Yeah,
so this is a good question. There are They're different. For each of these trials, there's certain things that folks are being selected. They're being selected based on. I think the most important thing is to have an open discussion with your provider and to ask, hey, what's going on right now in the world of remyelination? What do we know? What are the latest updates? I think that's opening that pipeline of communication is probably the most important way to focus on that.
That's great. And as you mentioned, here at OhioHealth, we have a large clinical trials program, and actually Dr. Jeff Eubank led the anti-lingo trials here at OhioHealth, so I'm sure we'll have more of those to come. And also another way that you can access information on where these are happening are to go to clinicaltrials.gov, and you can actually search for any clinical trial that's happening within the United States, which is really neat, and your physicians and nurse practitioners can help you with that as well. Now, what if I really don't want to be part of a research study, but I want to try to do something to help remyelinate my neurons? Is there anything that I can do to help with that?
In this case, we all have a system that we talked about for a little bit that is built within us that has the capability of doing some remyelination. We certainly wish it was more potent and more effective and could fix all damage. However, we do have something there, and I think the most important way to augment how well that works is to reduce brain inflammation right now. And so that's, I think, where the key feature to harp on is exercise, diet, treating comorbid conditions that impair blood flow to the brain. We want to have healthy blood flow to the brain in order to allow these mechanisms that we're made with, to do the best job that they can. And so I think that's probably how I would put that.
That's great. And we hear a lot about the importance of exercise, and then we hear this term neuroplasticity, and that's kind of confusing. Can you explain that and what the relationship is?
So when it comes to our brain, a lot of it is set and unable to change, but there's a lot of it too that is the plasticity term, is basically another way of saying that we have ways that the structure of our brain can, in some cases, be modified. We have some of these repair mechanisms available, and so we find that exercise in general is an anti-inflammatory thing for our brain, and it does help some of these repair mechanisms to kick in probably more effectively, and allow as much recovery, allow the brain to heal as well as it can.
That's great. So it sounds like exercise isn't just about strengthening our muscles.
That's right. That's a good way of putting it. It's not just, we certainly do want everybody to have a healthy heart and a vascular system, but even if you ignore that completely, we see that exercise for the brain specifically has benefits there as well.
That's great. And one of the other questions that came up was, how does myelin and autoimmunity occur? Are there conditions separate from MS that are involved there with myelin and autoimmunity?
Yeah, so that's a good question. I think comes up a lot. I think one thing to kind of keep in mind is that we still don't entirely understand why MS occurs, and perhaps it happens in different ways for different people. But there is something about the immune system that in each individual person's case where it's more excitable or active. It's doing things that it shouldn't be doing. So we see in general that there, in folks who have an autoimmune condition of one type, that there are other autoimmune conditions that they may have a higher chance of having. And so frequently when I meet someone and I talk to them about their MS, we may find or discover that in the family tree, even if it's up several levels, that there may be other autoimmune conditions that have run in that family. And so I think that there's a lot to be learned there, but probably there is a definite importance to our genetics, but not just our genetics, but also it's other things in the environment which may be triggering this problem for people.
That's so interesting. One of the things that a lot of our patients and their families are talking about when they come in is the stress that's going on in the world right now, and of course there's always stress, and it's kind of unavoidable. But what do you know, or what can you tell us about how stress affects MS?
So yes, stress is something that we all have to live with, But one thing we can do is find ways to cope with it and to get through it and to limit its impact on us as much as we can physically. So we don't have the control to eliminate the stress, but we may have ways to help us cope better with it. So we do see that as a generality, increased stress levels associated with increased blood pressure probably, which has negative impacts on our brain as well. And so I think when it comes to stress, it's important to target that in a number of ways. I think that exercise is key. For so many people, any kind of physical movement that they can do can be very impactful on helping to reduce stress, especially when you do it in as a habit. As you get into that habit of doing whatever type of exercise it is that you can do regularly, that action of making a habit really starts to come through, and stress levels can be reduced by that. Certainly there's also a lot of it affects our mood as well. The pandemic, it's isolating, it's socially isolating, and it's stressful to us psychologically. So maintaining good social contacts is key. Counseling can be very helpful. There's all different ways to target this, but it's important to realize that stress, I think we do have the power to do things to help modify it to some extent, and that's important for brain health.
Well, thanks so much, Dr. Smith. That was a fabulous presentation, and I'm always so excited to hear your insights on remyelination and repair, and I know that we're going to have even more in the years to come. So we're going to go ahead and move forward to my portion of the talk, and today I'm going to be speaking to you about some really exciting updates in multiple sclerosis. So every year in MS there is a large meeting called ECTRIMS, or the European Committee on Treatment in Multiple Sclerosis. And this past year, it was actually combined with ACTRIMS, which was the American Committee on Treatment and Research in MS. This is actually the largest research meeting in MS that happens worldwide every year. Last year we were in Sweden, and this year, unfortunately, it was a virtual event, obviously to keep everybody safe from the pandemic. But we were still able to share and collaborate and present a number of exciting research topics. And so I'm going to walk you through some of these topics. These are a few highlights that we felt were incredibly important, but certainly not all-encompassing of the entire event. So we'll go ahead and move forward. So first of all, I know you may be tired of hearing about COVID-19, but I just wanted to make a few points that came out of a really fabulous presentation that was gathered from a MS registry in the United Kingdom. So these are common questions that you may be seeing and you may be getting. But fortunately, the risk of getting coronavirus or COVID-19 is not increased simply because you have MS. It is also not increased because you've had MS for a long time or a short time. Being disabled does not increase your risk of getting COVID-19. And furthermore, taking an MS disease-modifying therapy does not make you more susceptible or more likely to get the virus. Additionally, in this study, it was shown that being on a disease-modifying therapy and having any degree of disability, which really means limitations in physical function or cognitive function, does not affect recovery from COVID-19. Now, I want to talk to you a little bit about another large study that was presented. As those of you here who may be patients of OhioHealth MS Center, we are doing our own COVID research study, and thank you to all of those who are participating in those MyChart questionnaires. This is part of a larger global data sharing initiative, and this was presented by Dr. Simpson Yap at the ECTRIMS meeting. And what this study looked at was a number of different registries globally where physicians and nurse practitioners, as well as patients, could enter information on themselves as to whether they developed coronavirus, if they tested positive, and if they were confirmed or just suspected to have coronavirus. And interestingly, what they looked at was, did different disease-modifying therapies or treatments that we're taking to prevent the worsening of MS have any effect on what might happen if we get infected with coronavirus? Fortunately, what we saw overall is that the majority of people with multiple sclerosis who get coronavirus are able to fight it off at home and are not requiring significant additional care to recover. However, it was interesting when they did this analysis of this study that they looked at patients who were on what we call anti-CD20 therapies. And so in this, these were medications like rituximab and ocrelizumab. And when they looked at people on these therapies, they found that if they were on rituximab or ocrelizumab as compared to any other medication to fight MS, those folks, if they got coronavirus, were more likely to be admitted to a hospital. If they were in the hospital, they were slightly more likely to require ICU care and slightly more likely to require mechanical ventilation or intubation. Fortunately, what was seen is that there was no association with an increased risk of death. So regardless of whether somebody got coronavirus or not and needed to be admitted to the hospital, that risk was not increased of not recovering from coronavirus as compared to anybody else on any other disease-modifying therapy. And there was another presentation that was presented actually by a large registry from the company that makes ocrelizumab that showed that patients on this therapy did not have a worse outcome or increased risk of death as compared to the general population. And this was generally seen to be more of an increased risk for people who were older with MS as compared to those who were younger. So another exciting talk was presented by Dr. Ellen Mowry, who is one of our colleagues at Johns Hopkins University and an MS expert. And at the ECTRIMS meeting, and for years, there's been a lot of discussions about escalation approach to starting MS treatment versus early, highly effective therapy. And what this means is, at the time of diagnosis of MS, we all know that taking a disease-modifying therapy is incredibly important to fighting the disease and preventing worsening. But there has been some debate in the field for a long time about the appropriate approach. The approach that initially started in MS, really because we didn't have any treatment therapies prior to the 1990s, was to start people on the, quote, weakest treatment for MS, which was also felt to be the safest treatment, and then switch to more effective treatments over time only if they had problems with relapses or new lesions on MRI. Now, the new guard or newer MS experts really seem to have a different opinion, and that opinion is really flipping the treatment of MS on its edge, where we've realized that if we give somebody a weak treatment to start with MS, and then we wait until they progress to put them on a treatment that's very effective to fight their MS, they've accumulated a lot of disability. And just as we heard with Dr. Dan Smith's talk, right now we don't have agents ready for prime time to fix the damage that's already done. So really, this early intensive treatment or treating with the most highly effective therapies early has really been a move in MS. Excitingly, there are actually two large clinical trials that are funded by PCORI grants that are being done nationwide, actually even internationally, to better understand what is the best approach, and also in addition to help prove the thought that many of us believe that early high efficacy treatment is the best way to treat MS. But these will demonstrate that in a randomized controlled fashion. So fortunately at OhioHealth, we're actually part of both of these studies. Deliver MS and Treat MS are pretty similar studies where we're taking individuals who are treatment naive or people who have never been on a treatment for MS and randomizing them to either starting on a high efficacy or a low to moderate efficacy treatment. There also is a treatment arm for people who don't wish to be randomized, who wish to select their treatment option to just be in what's called the observational arm and to start on any disease-modifying therapy of their choice. And then we'll follow them forward and we'll see what is the difference in the folks with MS who started on early high-efficacy treatment versus escalation therapy. And we'll keep you updated on that. But this is a very exciting study in the world of MS. So in MS, we always think we're really cute when we name clinical trials with fun names, but I do like this, the DISCO MS trial. So I highlight this because Dr. Corboy, who is a MS specialist from University of Colorado, presented at ECTRIMS a nice discussion where I think many people ask this question: is there a point in my MS at a certain age that I can safely stop MS disease-modifying therapy? This is a very controversial topic, and we don't know the answer to this. We do know that people can continue to get relapses and new lesions on MRI throughout their lifetime, but there may be some people, because inflammation becomes less active as you age, that at a certain point, they may be able to safely come off of their MS therapy. So this study is a prospective, placebo-controlled randomized clinical trial. And what they're looking at is to see, is there a difference in MS disease activity over a 2-year follow-up period in individuals with MS, if they're randomized to stay on their current treatment for MS versus stopping their treatment. Now, the patients that are being allowed or invited to enroll in this clinical trial are folks who are 55 or older, who are older than 55, and who have been free of relapses for at least 5 years and free of new lesions on MRI for at least 3 years. It's important to note that when we look at MS disease-modifying therapies, they have their greatest impact early in the disease, although we do see benefits lifelong. And we don't know yet really what the proper answer is. So I'm excited that this trial is something that is being done. We were invited to participate in this trial, but we decided we didn't want our patients to be the ones who went through this. We'd rather see what's happening out there with others. I suspect that there is going to be some variability between patients, and some studies have shown that if you stop MS therapy, even in the first couple of years of follow-up, about 11% of those individuals will continue to have relapses and new disease activity. So more to come on this exciting clinical trial. So what's up with the gut bacteria in MS? So this is really, really interesting, and I know it's kind of strange to talk about stool samples on a Saturday morning, but here it is. So the International MS Microbiome Study, or the IMSMS, was presented by Dr. Zhao et al. At ECTRIMS, and this study looked at stool and blood samples of people with MS and actually what was called a household healthy control. So somebody with MS and somebody that lives with them who doesn't have MS. And they included folks from across the globe in the United States, South America, and Europe. So there were about 576 individuals with MS, along with at least one of their household healthy controls, so somebody in their household who didn't have MS, and they studied them by looking at their diet, their stool samples, and their blood. So what were their results? Well, interestingly, it was found that people with MS actually eat healthier than their household healthy controls. And this was demonstrated by diet logs and seeing that they took in more fruits, more vegetables, and poly and monounsaturated fatty acids. What was really fascinating was when we studied the stool samples of people with MS compared to the people without MS in their households, a bacteria called A. muciniophilia was elevated in multiple sclerosis and not in the household healthy controls. The overgrowth of this organism was interestingly not affected by the diet. So even if people were eating different diets, they found that this was increased in the stool samples of people with MS. And this suggested that it might have a potential role in pathogenesis of MS. It's still unclear whether this would be a causal organism or whether it's somehow a byproduct of the disease process. So more to come, but I think that definitely the gut is a very interesting area of study in MS. So let's talk about some symptom management highlights. So nabiximols is a treatment that has been approved over in Europe for a number of years. So actually it was first approved in 2010 in the United Kingdom as a botanical drug. And this is a drug that is directly extracted from the marijuana plant. It is a spray that delivers about a 1-to-1 ratio of CBD and THC. And it's given sublingually or oromucosal. So you can see the picture here of the gentleman spraying this spray into his mouth. This has been used to reduce spasticity, neuropathic pain, and symptoms of overactive bladder and multiple sclerosis. And the exciting thing is that this study presented by Ben Zakaria really looked at a post hoc analysis of some of the clinical trials work that's been done to look at nabiximols in MS. So there were two phases of this post hoc analysis. Phase A looked at responders, so people who showed benefit with nabiximols, compared to non-responders, or people who tried this, who had MS, who didn't notice any benefit. And this was a 4-week study. And they looked at what were the differences. And they found in this group that responders had a mean reduction in spasticity of 44%. And they used a rating scale called the neurological rating scale. And non-responders only had about a 3% reduction. But interestingly, in this phase B of the study, where they were really looking at safety, they compared individuals on nabiximols versus those on placebo. And they specifically looked at the responders in this phase. And what they found is that it was overall safe and well tolerated, and that the most frequent adverse event that was seen was dizziness and fatigue. So I highlight this because I know that spasticity is a really disabling symptom in MS, and this is something that will ultimately be studied in the United States. It's a company called GW Pharmaceuticals, and there will be more to come on this in time. So is there a pre-MS period? I think this was one of the most exciting talks we can all agree from all of ACTRIMS. And this was presented by Dr. Helen Tremlett, who is a world-renowned epidemiologist in MS. And her question is a question that many of us have had. Of course, we know how to diagnose MS, and we know what the initial relapse symptoms of MS look like. But are there symptoms or signs in those few years prior to MS onset that can predict the risk of MS? And she actually answered that question by looking at health records and data in the years preceding the diagnosis of MS. Now, this is a slide that I used from her, so some of the spellings are different than they are in the United States for common words. But what she found was very interesting. So there was an increased healthcare use in individuals who later went on to develop MS, and this is labeled the MS prodrome. She found that people were more likely to be diagnosed with anemia, to report fatigue or increased pain, increased complaints about irritable bowel syndromes. People who went on to develop MS were more likely to have hospitalizations in the years prior to their diagnosis, even prior to having neurological symptoms. They sought out physician services more. They were more likely to visit psychiatrists or urologists and even dermatologists. They found that there were complaints about lower memory performance and that they had more prescriptions prescribed. They complained more of sleep disturbances and had increased headaches. So this is very interesting research because this may help us if we can identify what's happening in this MS prodrome period. We may be able to intervene early. We know that the earlier we diagnose MS and start treatment, the better people do down the road. We may use some of the biomarkers that help us to detect damage in MS, some of the ones that Dr. Dan Smith mentioned, like neurofilament light chain, which is a product that can be tested in the blood or the cerebral spinal fluid to measure damage in neurons. We may be able to look at imaging like MRI or other samples. So the question is, if we can further elucidate and clarify this MS prodrome period, could we prevent MS? If we can identify these problems in those years prior to onset, could we intervene and prevent MS from developing? So more to come on this. This is very exciting. So lastly, I want to end with probably the most exciting new MS therapeutic that I feel was talked about at the ECTRIMS meeting. This is called Mastanib. So Mastanib is an oral tyrosine kinase inhibitor, and it inhibits cells of the innate immune system. So these are mainly cells like mast cells, macrophages, and microglia. This medication actually has been used in the animal world to treat mainly dogs with mast cell tumors. Even my cat, who had mast cell tumor, was treated with this medicine. Little did I know that this was going to come and be an exciting therapy potentially for MS. So Mastanib was studied in a phase 2/3b clinical trial for progressive MS, and this was a randomized double-blind placebo-controlled trial. And they included individuals who had progressive MS who were aged 18 to 75. So this was both primary progressive and what we call non-active secondary progressive MS. So these were people who had a physical disability score of either walking with a cane or better. And then they were randomized to mastinib at a dose of 4.5 mg per kg per day versus placebo, and titrated to 6 mg per kg per day versus placebo. And the primary outcome was looking at, did they get worse in terms of their physical disability over time? Excitingly, this study showed that these individuals performed remarkably well. It reduced disability progression on the scale that we use to measure disability called the EDSS up to 96 weeks, and reduced disability progression by 42%. So basically, patients who were on this treatment were about half as likely to get worse in terms of their physical functioning. And 98% of individuals in this study did not reach an EDSS of 7, which means they did not progress on to being restricted to a wheelchair. So in summary, this treatment is the first-in-class tyrosine kinase inhibitor, which targets the innate immune system by inhibiting microglia and mast cells. And this may serve as a new treatment option for PPMS and non-active SPMS, so stay tuned because more clinical trials are headed our way. So I'm going to go ahead and answer some questions, and I'll invite Dr. Andy Smith to go ahead and ask me questions that are coming in.
Hi. So one of the most common questions we have coming in is, if I'm on a CD20 agent, should I discuss changing my treatment with my provider in light of COVID?
So I think that if you're on an anti-CD20, which means something like ocrelizumab or rituximab or the newly available ofatumumab, that's something that should be a detailed discussion with your MS clinician. Currently, we are not recommending that people come off their therapy because of COVID-19. We know that the effects of untreated MS are quite severe. And in the world of MS, the recommendations worldwide are that we should continue using anti-CD20s in people who require them for their MS. Now, there may be certain scenarios, perhaps where someone has been very well controlled and perhaps they're in their 60s or older, and there may be a medication that would be seen as lower risk or safer for them. And so those are instances where I think there should be a discussion about the risks and benefits of the medication, and where we might discuss potentially switching to a medication that may be slightly safer during this period. That being said, again, worldwide, the recommendation is to continue to use these therapies because they are very effective. And again, it should be noted that even being on these therapies does not increase your risk of getting coronavirus, and furthermore, it does not increase your risk of death from coronavirus. And so again, we recommend that if you're on these treatments, that you follow social distancing, wearing masks in public, and all of the safety guidelines recommended by the CDC.
Another question we have coming through is, for early intervention in MS, is there anything that would ever show up on the MRI prior to MS to signify early onset MS?
Absolutely. So, this is a pretty common scenario that we may see individuals who are referred to the MS center where they got an MRI because maybe they were having headaches or maybe they had some type of car accident. And they ended up getting an MRI, and there were abnormalities seen on the MRI that were lesions that looked consistent with MS. But when we talked to that individual, there's no clinical history of them having any neurological symptoms, and maybe their neurologic exam is normal. And so at that point, because there's no story of neurologic symptoms and no abnormalities detected on the exam, that individual would have what we potentially would call the radiologically isolated syndrome, or RIS, which we know is when somebody has damage on their MRI that precedes often what later will be a diagnosis of MS. And there are a number of studies actually looking at the radiologically isolated syndrome to see when should we intervene, or what are the risk factors to predict somebody who will go on to develop MS.
Is there any therapy for MS patients that we would recommend doing anything different in the setting of COVID?
So currently, I think the only thing that we would recommend different would be that, if you develop coronavirus. So if you are sick and you're diagnosed with confirmed coronavirus, that would be a point at which I would want you to immediately notify your MS neurologist and MS nurse practitioner to let them know so that we can help to advise you on how to be safe. We also want you to let your primary care doctor know right away so that they can help provide you recommendations for how to get through the symptoms. If you were due for an infusion treatment for coronavirus, we would delay that treatment until you were through the infectious period of COVID and until you were symptomatically better. If you are on an injectable medication, not an anti-CD20, those medicines, in my opinion, would be safe to continue. There would be scenarios where if you got infected with coronavirus and you were on an oral pill, that we might ask you to delay taking that for a period of time until you recover. But outside of that, there are not any major changes that we would recommend making to your MS disease-modifying therapy.
And another question we have coming in, particularly with the information about the gut, is do we need to be worried about occasionally binge eating sugar, which could increase inflammation, or staying out in the summer heat for a prolonged period of time? Is there anything that short-term could damage our immune system?
So the good news is that short-term enjoyment of bad foods or getting overheated doesn't damage your MS overall. We know that a diet high in sugar could be bad for MS, not only because of the way it makes you feel, but also because that would increase your risk of developing diabetes, which individuals with diabetes and MS progress faster than those without diabetes. So we certainly want to eat a heart-healthy diet and reduce that chance of developing other comorbidities like diabetes that can make your MS worse. But the occasional exciting, eating cake or sugar isn't going to harm you. And so everything in moderation. In terms of going outside in the hot sun, that can make your symptoms of MS seem more obvious or potentially worse. But some people aren't affected at all. That goes back to some of the work that Dr. Dan Smith was talking about, that our body and our nervous system is very sensitive to being overheated. And so if you get overheated, your symptoms of MS may become more apparent. If the heat doesn't bother you, there's no reason to avoid it. And so I know we're coming short on time here. I want to thank all of you so much for attending our first virtual event for OhioHealth. It's been a pleasure to have all of you here. Thank you for your engaging questions. I want to thank Dr. Andy Smith and Dr. Dan Smith for their fabulous talks. And I also want to just mention that because of coronavirus and also fatigue and watching virtual events, we decided not to have everyone from our team present today. But in the future, please look out for more of these because we would love to have Dr. Jeff Eubank, Dr. Doug Wu, our nurse practitioners, Diane, Jeanette, Colleen, and Laura present on all of their exciting areas of interest in MS, as well as all the incredible nurses, MAs, social worker, physical therapists, and our entire team at OhioHealth. Thank you so much for being a part of this, and I hope you have a wonderful rest of the fall weekend.